There you go.
That would be of interest.
The residents urged me to irritate you today.
Perfect.
So
probably.
I won't say which resident. I don't want to get anybody in trouble. But thank you very much. I really enjoyed meeting with the residents yesterday and at dinner last night. Today, I'd like to spend some time talking about screening. And you always need to start a talk somewhere, and I wanted to start with what we know. And I think, we know how PSA and DRE perform. We know that if you use PSA and digital rectal exam, there's a profound stage migration in North America. And at least from a histological point of view, most of the tumors you find are clinically are histologically significant. Now, I think even though this is a Canadian paper, I think it's a very good one from Neil Fleshner's group. Again, just showing in a sort of a smallish cohort in the Toronto area the powerful impact of PSA testing in reducing metastatic disease. And that trend, has been observed nationally in the U.S. and Canada for quite some time. But nonetheless, that is a very important study. But it's also revealing that screening not only induces a clinical stage migration, it induces a pathological stage migration. So even among men with sort of similar PSA values, in the last 20 years, the probability of pathologically and microscopically advanced disease has gone down. So I think, serial screening really does induce a substantial pathological and clinical stage migration. Now, I personally was perturbed about a year ago when Dr. Stamey, who I admire greatly, wrote a paper saying the PSA era was over, and I'd like to spend a few slides addressing that because I actually think he's wrong. I do want to also ask the question, though, are we using PSA properly? What is the right threshold? Should we be looking at velocity? I want to also ask the question, are we actually biopsying the prostate in the appropriate way? And finally, are all of our efforts truly, reducing the mortality from prostate cancer? Now, I apologize if some of you saw this slide last night, but for just purposes of starting the discussion, initially Dr. Stamey looked at the PSA in the most early time frames and saw very high correlations of PSA with these cancer parameters. But within the last few years, he said, well, gee, it's gone away. The correlation with these cancer parameters is gone, and that therefore PSA is between 2 and 10, essentially, is a marker of prostate volume, but not of prostate cancer. And while that may be true for his data set, I think it ignores a large body of evidence to the contrary. And one of them was the Physicians' Health Study, which consists of 22,000 physicians in the United States. And the powerful part of the Physicians' Health Study is that it looks at the development of clinical prostate cancer, not biopsy T1C type prostate cancer that many of the later studies discover. And it showed categorically that even among patients with very low PSAs, each stratum at baseline predicted your 10-year probability of developing clinical prostate cancer. Now, in a similar way, the PCPT trial essentially showed the same thing. It showed you what your 7-year risk of prostate cancer was, but in this case it's just biopsy detectable, not necessarily clinically detectable prostate cancer. And we can argue about whether these cancers are meaningful. And again, it varied in direct proportion to your baseline PSA. And there are other studies out there. I think this is a real eye-opener, showing again that PSA at baseline, even very minor differences in your baseline PSA, translated to substantial differences in your risk of prostate cancer over a 40-year time horizon. So I think PSA really is a leading indicator of prostate cancer. And finally, Bill Catalona looked at our data from 3 separate cohorts of the PSA studies at Washington University, and unlike Dr. Stamey, it continues to show good correlations between PSA and these parameters of cancer volume, and actually it's not quite as good at predicting prostate volume. So on the basis of all that evidence, I don't think the PSA era is over. But I do think the PCPT study showed us that we're not using PSA properly, because there are a fair number of men who have very low PSAs who have prostate cancer. And I tell the residents that we all should have seen this coming, because there was an influential but apparently not fully appreciated paper in the New England Journal a couple of years ago using some statistical analysis to calculate what the best cut points are to biopsy patients if you were to consider all of the salient parameters that indicate a man's risk for prostate cancer. You know, most of the studies have this verification bias where only men with high PSAs get a biopsy. But there are other things that are important for prostate cancer, such as your race, your family history, whether your digital rectal exam is normal, abnormal, or suspicious. And in any case, looking at these studies for men over the age of 60, the best cut point was actually 2.1, and you can see the sensitivity specificity. For younger men, they calculated a PSA cut point of 1.4. And I put the greater than 60 year in red because in the prostate cancer prevention trial, the actual study, a 2.1 cut point was associated with a 55 and a 70% sensitivity and specificity, saying that, you know what, that statistical modeling that was done about 2 or 3 years ago actually predicts pretty well what actually happened in the PCPT trial. So I think you could use these data to say, okay, we've got to use lower PSA cut points, and if you believe it and take it on face value, it will be 1.4 in younger men and 2.1 in older men. Now the problem is screening itself, and certainly screening with lower cut points, is going to really find a tremendous number of cases of prostate cancer. You know, Fritz Schroeder's study, a randomized screening trial in Europe, at least in the Rotterdam section, shows that if you're a nice compliant gentleman and you agree with the screening recommendations, you've increased your relative risk of T1C prostate cancer by 6-fold and your T2 prostate cancer by 6-fold. And that leads to a substantial over-detection of this disease, and we have to be honest about that. And if you just look at a comparison of your 10-year risk of dying of prostate cancer by your age, shown down on the bottom, and if you consider these various PSA cut points as suspicious, you can see that we're going to label in every case, maybe 5 to 10 times as many men as being abnormal or suspicious for prostate cancer than will ever die of this disease. And we truly do create an epidemic. And again, from the Rotterdam randomized screening trial, they sort of modeled what's going to happen over the long haul if you did one-time PSA screening based on your age, or if you did interval screening every year or every 4 years. And you can see that the rates of over-detection that they calculated are here, and your increased overall lifetime risk of prostate cancer being found on a biopsy versus your chances of dying of that disease is really substantially increased. So there's just no question that screening and lowering the PSA cut point is going to result in many, many, many more cases of prostate cancer than we probably need to find. Now, we need better tools to figure out, well, which cancers we find are meaningful. Now, there's going to be a tremendous explosion from Dr. Gleaves' laboratory and other places looking at molecular markers and all sorts of other things. But those are really going to take, I think, several years. I think if we would only do biopsies better, that we might be able to use some common histological parameters to actually figure out if the man in front of us has a clinically small volume, localized, focally localized prostate cancer, or a larger histologically and clinically significant one. The problem is that the conventional ultrasound-guided biopsy is operator-dependent. Even though we all sort of believe we spatially array these cores symmetrically throughout the prostate, they actually are quite random. We know that one biopsy session, 10, 12 cores, whatever, often misses significant pathology requiring rebiopsy. We know that the clinical biopsies often underestimate and overestimate the cancer grade and the extent on a radical prostatectomy. And finally, since I'm going to tease you and say I'm a kind of a proponent of developing some sort of focal therapy for prostate cancer, our current biopsy techniques provide really limited information about tumor location. And this is not really a new observation. About a year or so ago, one of our residents looked at 11 or 14 studies, analyzing all sorts of equations and formulas that are out there to predict, quote-unquote, insignificant prostate cancer or pathologically advanced prostate cancer using biopsy parameters. And the bottom line is that there's no single usable formula to say that a man has low volume insignificant disease or high volume significant or advanced disease. So I've sort of spent some time thinking about the problem, and we've embarked on two separate what we have termed template-guided three-dimensional prostate mapping biopsies. Now, these biopsies have the theoretical advantage of being reproducible, that 2 or 3 people could do the biopsy on the same prostate the same way. And I think that if you spatially array these biopsies appropriately, you're less likely to miss important pathology. You're more likely to accurately characterize the cancer in terms of its size and location. And this, I think, could substantially guide our treatment decisions, whether it's expectant management, focal ablation, or some form of radical treatment. Now, there's 2 approaches that we've been using. One of them is transperineal, and it's kind of like brachytherapy, but only for biopsy. And the other is a transrectal approach that we do in our office, the so-called target scan protocol. Now, the transperineal approach, patient has to be in the dorsal lithotomy position. It's exactly the way you put seeds within the prostate. Some people in the U.S. have done them in the office, I know, but I'm not patient enough or smart enough to put in the numbing medicine, so I usually do them in the hospital under general or spinal anesthesia. And you could make this as complicated as you want, but what I usually do is put the brachytherapy grid over the perineum. I divide the prostate into 8 octants, anterior, posterior, basilar or apical, and right and left. And depending on the size and shape of that particular octant of the prostate, I take as many cores as I need to truly sample that region of the prostate. Now, Dave Boswick has done some formulas, and he says, well, you should spatially array your biopsies 5 millimeters apart, because you don't mind missing 5 linear millimeters of cancer, because nearly every one of those small cancers would be clinically insignificant. Now keep that in mind. That's the perineal approach, and it has disadvantages of requiring anesthesia. When you take the 50 to 60 cores, as I'll show you, to sample your average size prostate, there's some bleeding, there's retention, it's not pleasant. Because that's not really going to be the long-term solution, we've been looking at this transrectal target scan approach. And this is done with a special probe that once the transrectal ultrasound probe is positioned in the rectum, it is not moved. The ultrasound transducer moves within the probe. There's a bendable biopsy needle that I'll show you that enters the prostate using what are termed Cartesian coordinates. And this is an office-based procedure under local anesthesia, just like every other biopsy. Here's just a picture of the machine. The key features are that the ultrasound transducer is moving inside this probe, back and forth, and it acquires all of the ultrasound information on the prostate within something like 5 to 10 seconds. And then you could reconstruct the slices of the prostate any way you want on the screen. This biopsy guide moves over the probe, and there are 2 main parameters. The depth of insertion from the apex of the prostate, that's one of your sort of numerical coordinates of where your biopsy comes from, and the other is a rotational coordinate, clockwise or counterclockwise with respect to the 12 o'clock position. And the biopsy guide, allows you to put in this special bendable nitinol needle parallel to the probe, but then it makes a 45-degree angle to go up into the prostate. And the beauty of this thing is, because the stylet of this biopsy needle is coming out in kind of a curvilinear arc, when the sheath comes over the top, it actually harvests more of the prostate per core than a straight-on, comparable-sized biopsy needle. And this is just a picture of a sagittal view of the prostate. I don't know if that projects so well, but you could put your biopsy in every 5 millimeters in from the apex of the prostate. Okay? And similarly, if you looked at this on a transverse image, you could take biopsies every 5 degrees. Okay? And in real time, we've been usually only using 12 cores because we haven't gotten really overboard on this thing yet. You can again see in a real patient where the biopsy needle tracks are on both the sagittal and the transverse image. Now, so far we've been using probably the most primitive biopsy algorithm. We've just divided the prostate, pretended it was a spherical organ, and that cancers were evenly distributed in the posterior half of the prostate, and we're just geometrically arraying these 12 cores evenly. But we know that's very naive, because we know there's actually more cancers in the apex and probably not so many at the base. And we have Burke from George Washington, not to be confused with Washington University, who has mapped the location of 5,000 cancers in radical prostatectomy specimens from Walter Reed, telling us exactly where the cancers are apt to be depending upon the size and the shape of the prostate. So we're going to have a different 12-core biopsy algorithm. But for now, we're just arraying these 12 cores, geometrically as though the cancers were evenly distributed. And when you take these biopsies, you get a record that tells you exactly where each of the 12 cores came from. So F just means a certain number of centimeters in from the apex of the prostate at minus 30 degrees, at minus 10 degrees, at 5 degrees, at 25 degrees. And you can see where each one of these biopsy cores came from. And if you send these cores off individually, you could truly map the location of the cancer in the prostate. Now, for American urologists, this sounds appealing mostly because of this line right here. As of January 1st, Medicare has this new code for three-dimensional imaging of the prostate, which you're able to do with this device, and that would allow you to bill and or collect more patients. Now, so we've been actually a little bit sparing in our use of these approaches. We've only been, until recently, biopsying men who are quote-unquote high risk. Well, what do I mean by that? Men with high or rising PSAs. You can see that these are a heavily pre-biopsy group of patients, so a median of 3, but a range of 1 to 6, a median of 5 previous biopsy sessions, a range of 2 to 11. Some of the men had PIN, some of them had atypia, suspicious for cancer, so on and so forth. But you can see on a clinical basis what our cancer detection rates are. And again, using the brachytherapy protocol, you can see that the number of cores we take is quite substantial, somewhere between 26 and 62, with a median of 34. And that's why it has too many side effects, I think, to become your everyday approach to biopsying prostate cancer. Well, rather than put a lot of patients through these mapping biopsies, we did the next best thing, which was to take consecutive radical prostatectomy specimens from men who had sort of our standard type of U.S. prostate cancer, PSA is 6.2, age of 57, and then simulate either or both the target scan approach or the brachytherapy approach. The residents would come into the room and do it on the specimens. And then one of our pathologists completely embedded the organ and we asked the question, does this simulation of a 3D mapping biopsy predict your radical prostatectomy findings? And again, this is sort of a not unusual series in the United States. You know, prostate volumes of about 50 cc's, tumor volumes of only 1.7 cc's, about half of them Gleason 7, 10% advanced, and 25 of them, even by histological criteria, probably insignificant. Well, overall, the 3D mapping approaches detected cancer in about 92% of the prostates. The cancers that it missed, the mean tumor volume was 0.09 mLs, plus or minus 0.14 cc. So the tumors they missed are very small and they probably don't matter. And all but one of the missed cancers would have been classified as insignificant, you know, using Epstein's criterion. One of them was small volume, but it was Gleason 7. And if you ask yourself the question, do we correctly classify each octant of the prostate as having cancer or no cancer, the mapping biopsies were right 82% of the time. And in about 25 of these cases, two different residents simulated the same biopsy approach on the specimen. And we wanted to know, could two people get the same results? And it was pretty good. Their octant concordance on the simulated biopsy was 88%. And again, by way of comparison, the clinical biopsies that led to the radical prostatectomy, as is fairly typical, undergraded the final radical prostatectomy pathology moderately, you know, frequently. By comparison, the 3D mapping biopsy was pretty much right on in classifying the final Gleason score. And if you could pick a parameter, like if you believe that what really matters is the percent of pattern 4 and 5 in a prostate cancer, you could just map a comparison of the radical prostatectomy and the saturation biopsy in the first 100 patients and then draw a line. You have an R-squared value of about 0.8. So that's actually a lot better than we're able to do. And if you picked a formula, and one of Epstein's formulas to define histologically insignificant cancer on a biopsy is a man who has only one positive core, which is less than 10% involved with cancer and is less than Gleason 7. The clinical biopsy had these sensitivities and positive predictive values, but the mapping biopsies had a higher sensitivity and a higher overall positive predictive value. And again, if you use a formula that defines microscopically and pathologically advanced disease, meaning any Gleason pattern 4 and 5, more than 5 millimeters, and more than one core positive for cancer, again, the clinical biopsies are pretty lousy, the sensitivity and specificity, but the mapping biopsies were better. They're obviously not perfect. But from where I stand now, I really do think that we need to do some sort of prostate mapping because as we get better and better at it, I think it's going to provide superior prediction of what is actually going on in that man's prostate. It's going to tell us a lot more about tumor location, about final Gleason score, and about whether there is insignificant or advanced disease in there. And we've started a 5-center study now just looking at the patients with sort of abnormal PSAs and digital rectal exams to see whether we will get the same results in patients as we got in the specimens. And I have to both thank my co-workers on this trial and also disclose that I've been a consultant and I have a very tiny equity stake in the Envisioneering company. Yeah, about 200,000 shares, and you know they're worth 0.00001 cents or something like that. Anyhow, okay, so here's the good news: prostate cancer mortality is falling. Is that because of screening and radical prostatectomy? I think it probably, at least in part, is due to that. And why do I say that? Well, I think that The Tyrol study, as you know, has showed about a 20 to 30% reduction in the expected number of deaths from prostate cancer in the Tyrol. The Scandinavian trial, which was a negative study for radical prostatectomy versus watchful waiting, became a positive study at 8.2 years of follow-up, and it seems very plausible. But on the other hand, you have to sort of acknowledge that in many countries throughout the world, prostate cancer death rates have fallen, but they, particularly, for example, in the United Kingdom, have not really done as much screening or as many radical prostatectomies as we've tended to do in North America. And there also are two, studies that actually suggest that screening and radical prostatectomy doesn't make any difference. One is conducted by the U.S. National Cancer Institute, the SEER program, which keeps cancer statistics. They compared what happened to men in Seattle to men in Connecticut. And as you know, practice patterns vary a lot. If you're a Medicare beneficiary in Seattle, you have 5.4 times higher PSA testing rate, 2.2 times higher biopsy rate, and a 4.2 times higher radical prostatectomy rate than your buddy in Connecticut. But after 10 years of follow-up, the prostate cancer death rate was identical in both places. Now that either says that screening and radical prostatectomy doesn't work. It says that this is not an intense enough rate of PSA testing and radical prostatectomy, or it says that a lot of guys move from Connecticut to Seattle and then die of prostate cancer, right? Plausible? There was finally a paper just last month in the Archives of Internal Medicine that looked at 10 VA medical centers in New England and did a lot of statistical matching of 500 men who died of prostate cancer and matched them to living controls. And they could find in the VA system no difference in overall or cause-specific mortality in men who had intensive PSA testing and men who did not. So again, for fair and balanced disclosure, although I sincerely believe that screening and treatment are good things, the data are not really there. And that's why I remain very much involved in a trial in the United States, the PLCO randomized screening trial. We actually have 76,000 and some men in the 55 to 74 age group who have been randomized to conventional care, which is no organized screening, or screening every year for 7 years. And this is unlike the PSA study we did at Washington University. This is multi-center, number one. But number two, if a man has an abnormal screening test, we don't automatically biopsy him. We send him back to his internist, and we ask his internist and the patient to make a decision, well, gee, should he have a biopsy or not? And so one of the criticisms of our PLCO study is that if you're a man at baseline and you had a PSA between 4 and 7, within 1 year, only about 25% of the patients are getting a biopsy. Within 2 years, again, it's about 40%, and then it kind of goes slightly above 40% by 3 years. And what this tells us is that, internists and the patients are looking at things probably like PSA velocity. Maybe they're having their PSA retested and it's, less than 4, and they're choosing not to biopsy the patient. And it's even true among men who have PSAs of greater than 10, that after 3 years of follow-up, only about 80% of those guys have had a biopsy. We think this is good because it's a real-world test of screening, not an artificial test of screening where we hold a gun to your head and say, get a PSA, and if your PSA is abnormal, we hold a gun to your head and say, get a biopsy. We're saying, hey, listen, let's use some judgment in interpreting these PSA values. And again, it looks like the medical community at large are interpreting the PSA values in a reasonable way, because if you have a family history of cancer, or if you're young, if you have a higher PSA elevation and no history of a prior PSA, you're much more likely to get a biopsy than if you don't have those features. And again, we found probably 2,000 or 3,000 cancers in people. And it's just what you expect. Only 6% of them are advanced, and there are some of the histological features. And we think it remains on course to actually answer the question about prostate cancer mortality reduction. And I have to say we're in discussions with Fritz Schroeder to somehow analyze the European study, which is randomized, and our study together, and maybe we'll get an answer a little bit quicker. The other thing I want to point out to the residents is that PLCO keeps a very big biorepository with these various collections at these time points. We have risk factor questionnaires and dietary questionnaires. We have a couple of ongoing studies using this biorepository for both prostate cancer and BPH. But the bottom line here is that extramural investigators are welcome to submit ideas. If you bring your own funding to this thing, you can have access to it. There's a small committee that looks at sort of the scientific validity of your work, and assuming you're not going to deplete any of the valuable specimens, we could send some specimens your way. We've been fooling around with some of our data just to kind of keep everybody interested in PLCO. One analysis was to ask the question, well, gee, if your baseline PSA is really low, and if you believe that PSA of greater than 4 was the magic number to get a biopsy, do you really need PSA testing every year? And again, if your PSA is very low at baseline, only 1.6% of the men had a PSA of over 4 within 5 years. So maybe these guys don't need annual testing. You're really not going to miss a lot of PSA elevations. And if you run the model and do 5-year testing for men with low PSAs and 2-year testing for men with some other ones, you could probably save a lot of money and reduce a lot of PSA testing. We've also looked at obesity. This is an epidemic in the United States, and I live in Missouri, and you can see we're in the 20 to 25% range of obesity. There are a bunch of studies out there showing that obese men generally have lower PSAs than non-obese men. And that may be hormonal, but it may just be obese people have a bigger extracellular fluid volume, so you're dissolving the PSA in a bigger total body water. And if you have obesity, in at least one study, although this is controversial, it says you're going to do worse after a radical prostatectomy. In PLCO, the PSA levels are lower among obese men than non-obese men. The risk factors for a positive biopsy, a BMI of greater than 30, has this odds ratio here, and that was statistically significant. And there was a trend for worse overall biopsy-grade, high-grade cancer in obese patients. So I think there's probably something to it. And again, I'd like to just thank some of our PLCO collaborators. Robert Grubbs, one of our junior faculty members, Dave Crawford, and Don Urban, you likely know. And this is the part meant to irritate Larry and maybe Marty. And I'm not going to spend too much time on it. But as I told the residents yesterday, I personally believe that laparoscopic or robotic radical prostatectomy is the gold standard. And I say that, I think the data, admittedly it's not a statistically valid, direct side-by-side comparison, but if you just chunk together Walsh, Scardino, Mayo, Catalona, UCLA, and my personal series, and some laparoscopic and robotic series from Guilleneau, Abu, Rossweiler, Money, Menon, and so on and so forth. Yeah, they're not exactly the same patients and all, but you know what? When you look at all the main parameters, lap prostatectomy looks better to me. Transfusions rates are definitely lower. Among the experts, there's about an 11% transfusion rate. Marty Sanda has a health-related quality of life study that he's doing for the NIH. And again, in that study, we had no transfusions laparoscopically and 20% in the open group. And this is multi-center throughout the United States. I don't want to, really spend too much time, but boy, when you line things up based on the published literature, lap looks at least as good and probably better. Some people don't like it because it's not 3D. Well, as I told the residents, there's this nice 3D camera. We did some work in our pig lab with inexperienced laparoscopic surgeons, and it improves task performance by 20%. And it really gives you a personalized view of what you're doing. So I would encourage anybody who's interested in complex laparoscopic surgery, whether it's partial nephrectomies or radical prostatectomies. You don't need a robot, no offense, and you should just get your laparoscope out and put your 3D headset on and let it go. And I've converted from the transperitoneal, as I mentioned yesterday, to the extraperitoneal approach. And to me, it simulates exactly, the classic, open extraperitoneal radical prostatectomy. And the only final thought I want to leave on this is that I was recently in Europe, and two of the prominent European surgeons are doing this, as is Money Menon, this intrafascial laparoscopic radical prostatectomy, where you don't open the endopelvic fascia, you don't divide the puboprostatic ligaments. It makes for a terrific post-operative picture. There's a lot of tissue down there, and you can convince yourself, boy, you're really leaving nerves behind. But when you are in the OR and you actually scrutinize the specimen, they look pretty rough. And I know that my pathologists who look at our specimens pretty carefully, I think would give me a pretty hard time. So I don't want to belabor the point. I'd love to spend some time handling some questions. I guess the bottom line is that I think we actually should be using lower PSA cut points, and that we're going to biopsy patients actually more frequently, but that if we do better biopsies, some sort of geographic biopsies, we would have both better detection and we'll make better treatment decisions. I know this is almost heresy, but I really would say don't discount focal therapy, because we find so many small cancers. And this may be a comfortable alternative to watchful waiting or some form of radical therapy. And if radical therapy is warranted, I personally think the laparoscopic